Okay, thank you very much for your kind introduction. Hello everybody, my name is Riki Matsumoto. I am from Kyoto, Japan, and I am a neurologist as well as an epileptologist. And I do my clinical activities as well as doing some research activities, sharing a common interest with Dr. Marco Catani. And it was very kind of him to accept my visit to his lab and have an opportunity to talk in this distinguished group. And I'd like to talk about imaging human cortico-cortical connectivity using cortical stimulation. As all of you know, cortico-cortical connectivity in humans, regarding that, the majority of knowledge has come from invasive tracer studies of non-human primates in 20th centuries. Until very recently in this century, the corresponding knowledge has almost exclusively come from the post-mortem studies, such as gross dissections, or some people use ammoniacal silver impregnation of degenerated axons. For example, if there is a lesion here, then we can trace the degenerated axon into the other part of the brain. But obviously, it has some limitation to control the location and size of lesion. And for gross dissection, it is quite difficult to trace large fiber bundles into specific cortical areas. Recent advancements in this century have brought possibilities to trace cortico-cortical connections in our living human brains. For example, diffusion-weighted imaging that is very popular here in this institute is diffusion tractography that revolutionized our understanding of the in vivo human dissections of white matter fasciculi. And also some fMRI studies can trace networks using functional connectivity analysis, such as resting state connectivity, functional connectivity, or using some modeling such as effective connectivity using PPI or DCM. And what I am quite interested in is so-called invasive electrical track tracing methods, stimulating a part of the brain and recording responses from the surface of the cortex using cortical evoked potential methods. And this has been also popular in people using TMS as a non-invasive technique to stimulate a part of the brain and recording responses, presumably by cortico-cortical projections. This is what we developed when I was a clinical fellow in Cleveland Clinic in year 2000. As a neurologist and epileptologist, we are very interested in how seizures or spike propagates by brain networks to produce seizure semiology or seizures. And this is a very simple technique which we try to apply what we know to map to study the motor system for clinical as a part of clinical mapping. As you know, when we stimulate the motor cortex with TMS, transcranial magnetic stimulation, or directly with single pulse stimuli to the brain or the cortex, we can record. We can activate the pyramidal neurons, and then we can see the excitation by muscles by recording motor evoked potentials. What we thought is by using the same technique and apply the single pulse stimuli to the part of the brain, and then we wanted to record the cortical evoked potentials by excitation of cortical projection neurons. By just stimulating the brain with single pulse and recording evoked potential from the other part of the brain, which we term the cortical evoked potential, CSEP. And this was a very simple technique, but it works quite well in our patients, clinically, both as well as to study the brain functional networks. This is a quite easy study to apply in the clinical setting. We apply single pulse in a frequency of 1 Hz, and in alternating polarity to for the safety issue to preserve the cortex from the possible impairment by currents. And we apply usually 20 to 30 pulses That means we can study the connectivity pattern from one side of the brain about in 1 or 2 minutes. So it's quite easy technique. And we don't ask patients to do anything. So they can sleep, even sleep, and then we can get the response from the brain. In contrast to diffusion tractography, that is determined by mathematical calculation of anisotropy of water molecules. This technique, CSEP, provides a unique opportunity to physiologically track in vivo cortico-cortical networks, although applicable only during the invasive evaluations. It does have excellent time resolution because this is a evoke potential studies, and also has a fairly well temporal resolution that is inter-electrode distance of the subdural electrodes, 1 centimeter. Well, this kind of single pulse stimulation has been popular in the last decade. This is an editorial from Dr. Alapon, I think from this institute.
Just across the road.
In neurology. I know him by name, and I also met in some conferences, which has a common interest to stimulate the part of the brain. And this technique has been called as CSEP, as we say, or single pulse electrical stimulation, SPES, as Dr. Alapon's group says. And this has been used for two purposes. One is to use CSEP as a marker of cortical excitability for localizing the epileptic focus. If we stimulate a part of the brain within a seizure network, the reaction response would be larger. That is hypothesis. To use this to map the epileptic focus. The other thing is mapping functional cortico-cortical networks as a part of pre-surgical evaluation. When I go back to see PubMed, there's now around more than 10 articles studying this cortico-cortical networks using this invasive track tracing method. And also this has been applied extensively to study epileptogenicity of the brain as well. And let me focus on some functional studies we have done, this time focusing on the language study as well as Parietal-frontal networks. This is where this is my university hospital in Kyoto. I'm sorry the contrast is not good, but you can see some Chinese character here in the mountain. That means big. And we have our lovely city of Kyoto, an ancient capital of Japan, is surrounded by this kind of mountain. I'm lucky enough to live in the central city of Kyoto, and I can see these mountains. And in the summertime at night, these mountains are lit with torches to celebrate our ancestors to come back to our home. That's what we believe. And this is a roadmap of my talk today. First, I'd like to talk about the first study we did for human network proper in humans, that is language. And secondly, focusing on Parietal-frontal network. And if time allows, I may come back to study the language pathways within the temporal lobe. That is not well known or settled down yet. And hopefully, if time allows, I'd like to shortly mention about generator mechanisms of this CSEP technology. This is the first study we did. This is an example. We can locate the language areas by conventional 50 Hz cortical stimulation. That is a gold standard method to map the human brain functions for patients who need this kind of invasive evaluation to map the functions as well as epileptic focus. This red electrode is a language electrode defined by cortical stimulation, 50 Hz. And if we apply not 50 Hz but single pulse stimulation, single pulse in 1 Hz frequency, and if we average the response, let's say 100 times, we can get this kind of evoke potential from the other part of the brain. This is a lateral temporal area, grid on it, and this vertical bar corresponds to the timing of the stimuli. So you can see that from the temporal lobe stimulating Broca's area, we can get this kind of focal response at and surrounding the language area defined by core language area defined by 50 Hz stimulation. Sorry, contrast is very bad. I'm so sorry. Maybe because it's black. Please imagine there is a brain here. I can see, but you may not. Sorry for that. This kind of connectivity was very site-specific. This is stimulating Broca's area, and that is stimulating face motor area, just 1 centimeter posterior to the site of Broca's stimulation. And if you stimulate Broca's area, you can see the response that is colored in circle, colored in yellow, like from this area. This is temporal lobe, please believe me. This is Sylvian Fisher. So what is interesting is, more than I expected, there is a broad connection not only to the classical so-called Wernicke's area, but also to the supramarginal gyrus. And if we stimulate face motor area in return, in this case, no response from the parietal-temporal cortex, but from the postcentral gyrus, with shorter peak, shorter N1, potential latency, compared with the Broca's response, 25 versus 13 milliseconds. And this kind of connection from Broca's area to the posterior language area, this was bidirectional, because if we stimulate the language area in the posterior part of the brain, that is Wernicke's area, we can also get the response from the Broca's area as well. So for the first time, we could tell that with this method, what we believed is also dynamic excitation. We could say that this network is bidirectional in terms of electrical physiology, electrical neurophysiology. For the distribution, by stimulating Broca's area, you can see yellow circles as a distribution of these CSEP potentials. As you can see, it's somehow widely distributed in the lateral temporal parietal area, not only confined to the classical Wernicke's area in the posterior part of superior temporal gyrus, but also to the middle temporal gyrus or supramarginal gyrus. Or sometimes, yes. And this is quite matches with seminal work of Dr. Katani in 2005, in which he proposed 3 pathways from Broca's area with the DTI technique. Broca's area connecting to the Wernicke's area, as well as shorter circuit connecting to the parietal area. And that quite matches with what we found with our method. I may come back to this issue later, but when we stimulate Broca's area, and we had the opportunity to record from the basal part of the temporal lobe, because sometimes patients may have epileptic focus in the at and around the hippocampus. If we stimulate the Broca's area, we can record the response from the basal temporal area. But if we stimulate face motor area, just 1 centimeter posterior to the Broca's area, there is no connection to this basal temporal area. So it's again site-specific. On the other hand, stimulating Wernicke's area, only we had an opportunity to stimulate in 2 patients. It was not robust, but surrounding areas just posterior to the core language electrode was able to produce some response from the basal temporal area. I may come back later. And the cortico-cortical network within the pathology, because we want to map the language network in our patients, epilepsy patients who will undergo focal resection of the cortex, epileptic focus. We want to preserve their functions, brain functions. So in that way, we want to know the language network distribution. In patients having a so-called cortical dysplasia, that is a misarrangement of the neurons in the cortex, which showed high Fourier density here. Stimulation of the Broca's area showed a network connectivity outside the lesion. And in case of cortical dysplasia, which is widely scattered, the language cortex seems to be divided or separated by abnormal tissue in between. So in this sense, CSEP could be clinically useful to identify normal functional cortico-cortical networks within the pathology. This is our Kyoto, and we have a river called not Thames but Kamo River, and there we can enjoy our sakura blossom, cherry blossom trees in springtime. And you can see some mountain here which has a mark of the ship there. Yeah. We can enjoy their torch in summertime, only in one day. Okay, now let me move on to the Parietal-frontal network. Since I found that there is a network between Broca's area and the supramarginal gyrus, that is parietal area, I also was quite interested in knowing how the brain is wired between parietal lobe and frontal lobe to preserve for our brain functional networks. As you know, this network is essential for sensory motor transformations for complex behaviors, and its disruption is associated with pathophysiology of apraxia, mainly for the left hemisphere, and visuospatial disorders for the right hemisphere. And it is responsible for rapid spread of spikes from the posterior hemisphere to the anterior hemisphere with regards to epilepsy field. And it's very difficult when you compare a monkey and our human brain site architecture. It is quite difficult to directly apply monkey connectivity studies findings to newly appeared regions in the parietal lobe. That is inferior parietal lobe, broadband area 39 or 40. So that was so we aim to explore human parietal-frontal networks with CSEP methodology, and in this study, with the advent of imaging methodology, we wanted to provide a standardized CSEP connectivity map as a reference to the basic as well as clinical system neuroscience. We recruited 6 patients who has partial epilepsy and who needs to implant chronic implanted subdural electrodes on the brain for 2 weeks as a part of pre-surgical evaluation. This is one representative case. Sorry, it's hard to see. This is a lateral view of the brain. This is central sulcus, temporal lobe. So this is angular gyrus. If we stimulate angular gyrus and recorded response from the frontal lobe, that is shaded yellow, white here, with landmarks here, central sulcus, precentral sulcus, superior and inferior frontal sulci. If we stimulate angular gyrus, you can get response from the premotor area, dorsal part and ventral part as well. So these 2 separate areas. If we move the stimulus site to the supramarginal gyrus, you can have a different net connectivity connections. One into the premotor ventral, 1 centimeter posterior to the angular gyrus stimulation, and also in the precentral gyrus like this. If we stimulate postcentral gyrus, now you can get a huge, large response, presumably by a rich U-fiber connection in the precentral gyrus here. That is face motor area. So as you can see, as the stimulus site gets closer to the central sulcus, the response site seems to get closer. We want to check this kind of network configuration using MNI standard template, putting all the patient information together there. Thanks to anonymous reviewer, we tried to use a state-of-art site architectonic atlas from Tilles group in Jülich, and we tried to apply their map that was made in the parietal lobe, but only some in the frontal lobe and temporal lobe. And in this way, we can locate the site of stimulation in accordance, in reference to their atlas. For example, this patient we are stimulating, it's hard to see. This is a supramarginal gyrus here, and we got response, 3 separate response from here. One is from the middle frontal gyrus, other 2 from the inferior frontal gyrus, upper part and lower part, separately. And we can, the middle point of the stimulus site can be located here in the MNI place. According to the atlas, it is at the PFM, posterior part of the supramarginal gyrus. And then we can get the largest response that is here into there, and separate additional response here. The largest response showing a predominant connection from the site of stimulation. The other two is additional but separate connections. This is the result for the whole patients. As you can see, sorry for the bad slides. There are several configurations in this Parietal-frontal network. First, as I showed in a representative case, there is a near-to-near, distance-to-distance, near-symmetric configuration across the central sulcus. Let's say stimulating the post-central gyrus here show the largest response from the pre-central gyrus. The same applies to the ventral part. But if the stimulus sites get more distance from the central sulcus, like stimulating supramarginal gyrus, response gets a bit distance. And in case of the angular gyrus stimulation, sorry, it's hard to see from here, it's getting more distal. And the second sum of rule is preserved dorsal ventral organization. For the maximum response sites, the dorsal stimulation gives rise to maximum response in the dorsal part of the frontal lobe, vice versa, ventral to ventral. And this was natural but more than expected. When we stimulate the parietal lobe in a macroscopic way with 2 centimeter, 1 by 2 centimeter part cortex, we can get projections in the frontal lobe in more than 2 sites, in more than 50% of the explored connections. And this was again confirmed by the regression line analysis in individual brain space. Let me show some of them in detail. For the dorsoparietofrontal circuits, although we don't have so many patients having grid in this part of the brain, we can see that this anterior Brodmann area 2 dorsal part, means the anterior SPL, superior parietal lobe, will have connections to the Brodmann area 6 dorsocaudal part, means like here. And also this part, 7 PC stimulus site is here, gave rise to response here. That is appreciated here in the table. Response from the Brodmann area 6, dorsal part and ventral part. And from 7A, that is posterior part of S superior parietal lobe, it has connection to the basically premotor dorsal area, but as well as ventral part. This is a simulation of the ventral parietal-frontal circuit. The more anterior part like this, that is termed OP4 or PFOPT, anyway parietal operculum. Simulations there give rise to this response from the adjacent precentral gyrus or the Brodmann area 44. Stimulation of the supramarginal gyrus, you can see a quite difference when stimulating the anterior part and posterior part. Anterior part stimulation gave rise to response from the Brodmann area 44, as well as response from the precentral gyrus here. In contrast, stimulation of PFM shows largest response more rostral, not in the precentral gyrus, but in the Brodmann area 44 or premotor dorsal area. Stimulation of the angular gyrus, although the stimulus site is not so many, anterior part stimulation gave rise to the response from the premotor dorsal, as well as the Brodmann area 6 ventral part and BA40. This is premotor ventral area. On the other hand, the more posterior part of the angular gyrus gave rise to the response from here, middle frontal gyrus. That corresponds to the Brodmann area 44. And this is cited from Michael in this lab. They made this kind of very clear fasciculi, and I realized that this was made from one single brain. That is your brain. And there is a clear separation in the superior longitudinal fasciculus, number 1, 2, 3. And I think what we found here provides or complements the findings provided by diffusion tensor tractography by giving the starting and target quantities for SLF. For example, this supramarginal gyrus circuit to the ventral part of the premotor area, Broadman area 44 or precentral gyrus, may be conveyed by this third fasciculus. And for the angular gyrus, this area, that area connecting to there and there, would be by this SLF the second. And the superior parietal lobe network, although number is small, may correspond to the first fasciculus. Regarding the dorsal root, as you know, this is involved in reaching movement and its pathology of optic ataxia. fMRI activation study shows in reaching or pointing task activation of both areas, and this is a lesion having optic ataxia, again corresponds to that part of the brain. And we had an opportunity to find a patient who showed misreaching when we are stimulating part of the superior parietal lobe with 50 Hz stimulation for 5 seconds. And that part of the brain again was connected to the middle frontal gyrus. That was also appreciated or confirmed by probabilistic diffusion tractography. For the ventral network, for language, it would be related for the verbal fluency, as shown by Dr. Katani's this network. And also, white matter stimulation of this network gave rise to impairment of verbal fluency. And also in the left side, that is also involved in praxis network, which impairment give rise to idiomotor apraxia. On the other hand, for the right hemisphere, that is related to spatial awareness. And the connection there was beautifully studied by Michael, I think, in this year. Probably ventral part would be subserved by this network. And in this way, by making this kind of table cytostimulation and cytofrontal response, this could give us a standardized connectivity map library in the MNI space. And this kind of standardized map from electrophysiological point of view can provide a reference for the non-invasive connectivity studies. This was a combined study of the CSEP and resting state fMRI from Albert Einstein group in New York. They stimulated the Broca's area as we did, and they recorded CSEP from the Wernicke's area or posterior language area. And they found some significant correlation between the maximum, between the amplitude of CSEPs as well as the depth value of the resting state connectivity. As a clinical epileptologist, we want to apply this network mapping to preserve our brain functions of our patients. And this is a case where MRI shows nothing in 3 Tesla machine, but the patient seems to have intractable epilepsy from the parietal or temporal lobe, according to the non-invasive studies, including MEG. So we finally put the large electrodes here to map the site of epileptic focus as well as her brain function in the dominant hemisphere. As you can see with colored with blue, we can find a language electrodes here. And in the along the central sulcus, colored yellow and red, these are motor and sensory findings. This is along the central sulcus, face or tongue response and hand response here. Posterior to it, in the supramarginal gyrus, we found an area that shows selective impairment of the pantomime of tool use. And let me show that with consent from, with permission from our dear patient. This is how we do the cortical mapping with 50 Hz cortical stimulation. To study the higher order brain functions, what we do is we gave the patient some task for language reading some paragraph, and for in this instance we are showing some word, Japanese word, showing tool name, and ask her to pantomime. And this is the timing of the, excuse me. This is the timing of the stimulation, and I will tell you the timing. When we stimulate the brain, you can see noise from the EEG. And the patient have a difficulty doing a gesture of key. She did the same thing, preservation of what we asked to do for the pencil. Let me show now. Now showing hammer, screwdriver, scissors, stimulon, pencil is fine. The key, she did the same pencil stuff. Stimulon off, stapler is fine now. That is okay. Spoon is fine. So just during the stimulation, the patient was not able to do the tool gesture pantomime. That was reproducible. We need this kind of reproducibility to confirm that patient has some specific cortical function. Reproducibility is very important for surgery. And what she said is she knew the name of the tool and how to use it, but she cannot perform the tool use. And we checked others' symptoms. She was okay during the stimulation, 50 Hz stimulation. She was okay for simple movement and the actual use of the tool, as well as naming the tool, saying hammer or screwdrivers, and also complex motor behaviors such as reaching or grasping, and also the gesture of the handshake. Because the patient has no lesion on MRI, and this is more higher order function. We wanted to know whether this area is really related with tool use, which impairment give rise to idiomotor apraxia. We want to study the network of this area to confirm this is really a part of the practice network. If we stimulate here, that is not posterior to the site of impairment site of tool use gesture. We stimulated here and recorded CSEP from the frontal lobe. We got tiny response from the premotor ventral in Broadband area 44. If we stimulate just on the area, we got larger response from there, pars opercularis. And if we stimulate more anterior part in the postcentral gyrus, we got robust response much larger in the precentral gyrus, and this is smaller than that. So in this way, we can confirm that there is a site-specific connection between these two areas. And this quite matches with the fMRI studies showing a tool use network that consists of the inferior parietal lobe and premotor ventral area. So CSEP investigation would complement conventional functional mapping, cortical mapping, by delineating the cortico-cortical network involved in the related function. In this way, now we can map the system of a functional network of the brain for our epilepsy patients to preserve their higher order brain function. Interestingly, in this patient, this area, as I showed, the patient showed a selective impairment of tool use gesture. But on the other hand, in the area where we got the site-specific connection by CSEP, that is a pars opercularis there, colored blue, stimulation there showed so-called negative motor response. That is, what we ask if the patient did not show any clear muscle twitch by stimulating a part of the motor cortices, we ask a patient to do this kind of simple movements, that is repetitive, a bit more complex than a fine movement like this, or wiggling the tongue. And when we stimulate the brain, sometimes the patient stops doing this during the duration of stimulation, which we call negative motor response, which may be related with more higher motor output. And this area showed a clear negative motor response. It may be hard to see, but the patient is doing this and wiggling tongue. Please believe me, she is doing. Now she is doing stim off, stim on. She stops doing this, stop wiggling tongue, off stimulation. We start doing it. So in this way, by seeing the result of 50 Hz conventional mapping within this practice network, it seems to me that there is a different role between them. The posterior part is more specific to the tool use gesture engram, how to do this, how to do the tool use. And for the output part in the premotor area, it is more general impairment, suggesting it's impairment of the movements in general, not only for this tool use, but for general motor.
Sorry, if you stimulate the blue one,
yes,
while they're doing the tool use gestures,
it was okay. Sorry, no, it was not okay because this simple movements. It's not simple, so simple, but this was arrested. That means we cannot check tool use here.
Right.
So that's the reason we did not check it, because this simpler movement even stopped. So in that sense, we believe it's a kind of virtual lesioning by 50 Hz stimulation, transient stimulation, without any complex chronic compensation. It's showing a kind of limb kinetic apraxia, although it is not slow but stopped totally. And that area in the MNI space corresponds to this area, and it is within this supramarginal premotor ventral network. So this, I think, it was reproducible in another patient, and we feel that it does have a practice network. It's not only the practice, but practice one of the network, one of the functions within this network. In the left language dominant hemisphere, because we want to treat our patient, and these patients have a large epileptic focus, including basal temporal area, lateral temporal, as well as some part of parietal area. So it was a very difficult surgery. After a thorough discussion with our neurosurgeon, he first get rid of this area, preserving core Wernicke's area, or posterior language area. And then we made the patient awake. What happened was patient showed severe anomia. But we have to treat the patient, so we wanted to remove more epileptic focus, including here, in awake setting, to show that there is no more impairment. And finally, we get to some sort of multiple subparietal transaction. That is cutting cortex every 5 millimeter to leave the functional column, but impair but to stop the horizontal connectivity. And in that way, we are preserved. And this method is believed to preserve functions here. And what we found is, after the surgery, anomia is severe, but as far as she could understand the language, she was able to do the tool use pantomime. So in this way, by preserving the tool use area, she does preserve this praxis network. And this is the central city of Kyoto, where I walk to my university hospital. This is the Imperial Palace. And you can see Japanese houses here, and we can enjoy autumn leaves in November now. Now let me talk. I still have some time? Okay. Let me go back to the language pathways. Since now it's a bit different, there is a debate regarding the connections within the temporal lobe. According to fMRI activation studies or lesion studies, several people argue that there is a dual language pathways. Based on the monkey auditory system, dual system, one is a dorsal wear stream pathway, and the other is a auditory ventral what stream. Researchers proposed two pathways for language as well. The first is dorsal pathway. That is believed to be related with action to articulation mapping. The other is ventral pathway, important, presumably for action to meaning mapping. And when I went into some review articles or some original articles, people said several things. That is not always the same. That is still will not settle down by Dr. Hickok and Popel. All of them says there is a dorsal route by arcuate fasciculus from the temporal parietal area, superior part, to the Broca's area. This is from Dr. Friedrich from Max Planck, and this is from Manchester's group. And for the ventral pathway, let's say for speech processing, it starts from the primary auditory cortex for the dorsal map pathway via superior temporal gyrus or supramarginal gyrus to the Broca's area, and for the ventral pathway to the anterior part of the superior temporal gyrus, then presumably by extreme capsule to the Broca's area. And regarding middle temporal gyrus, some people believe posterior part of the middle temporal gyrus is a part of the ventral stream. Others do not say so. And one more place, that is the basal part of the temporal lobe, anterior part. That's what we call, from our epilepsy surgery point of view, basal temporal language area. When we stimulate there with 50 Hz stimulation, when we stimulate with higher intensity, patients cannot do anything, including reading, naming objects, or understanding some simple verbal sentence order. Open your mouth or close your eyes. A kind of global aphasia could occur by stimulating here. And this is that is so-called yes. With our technique for the mapping, we can locate posterior temporal language area as well as basal temporal language area, and sometimes not on every occasion, but we also can have language impairment in the anterior part of the temporal lobe. Some patients in the part of the superior temporal gyrus showed selective impairment of auditory comprehension of the either sentence, not in the word level. We found 3 patients so far in this part of the brain. And what we wanted to know is a connectivity pattern between these language areas defined by gold standard method. And we recruited 9 patients who had, in total, we had 34 electrodes on the brain, including temporal, basal part of the temporal lobe and lateral part, and some of the frontal and parietal area as well. All had a language dominancy in the left hemisphere, defined by intracarotid propofol test, a modified WADA test. And for language mapping for 50 Hz stimulation as a part of clinical pre-surgical evaluation, we do several task batteries, and we try to define core language electrodes. If the multiple task is impaired, we believe that implies it's much more involved in language processing. That's the reason we do at least 5 tasks, including expressive tasks such as object naming or receptive tasks such as word picture matching. And for the localization of electrodes in this era of 21st century, now we can do good correlation into the pre-MRI, MRI taken before pre-MRI, and into the MNI standard space. It's hard to see. We always take MRI after grid implantation because the electrodes are made of platinum that give rise to signal void. In this way, we can locate electrodes manually and put the dots here. Our PhD doctors do it one overnight, but it takes some time because we have only 1 or 2 week implantation. We have to do this before surgery for mapping parts, and then we can transfer. We can locate like this. Then we can do the nonlinear correlations. By doing this, we can locate electrodes at very clear anatomically on gyrus level in individual brain surface, and then we can register this into MRI before, and then go to MRI. And we stimulate 3 parts of the brain and recorded systems. This is one example. In one patient, we stimulated this part, that is very anterior part of the anterior frontal. That is colored blue here. This is temporal lobe, this is frontal, this is parietal lobe. A vertical bar corresponds to the timing. As you can see from the surrounding cortex, as is a general rule, wherever we stimulate the brain, we got a huge, large response from the surrounding part, presumably by short U fibers. In addition, you can see that this is like this. Then we can get different response which maximum point is colored in red. For example, one from here, and one from there, and one from middle temporal gyrus and superior temporal gyrus. These are separate in terms of latency, and one in the posterior part of the superior temporal gyrus, smaller but isolated one in the inferior parietal lobe, and some in the ventral frontal area like this. Then we can locate like this separate response that is colored in large circle is language area. Green is non-language areas. In this way, we can put all the information into the MNI space. Blue area is site of stimulation. Remote responses in the language area, red. Non-language area, green. This is the results of the anterior language area, ATLA stimulation. We are able to stimulate here in the anterior temporal gyrus. Then what we got is response from the basal part, very anterior part, as well as from the superior temporal gyrus, and some in the middle temporal gyrus. If we stimulate the posterior temporal language area, that is so-called classical Wernicke's area, that is here. When we stimulate there, we could record response from the basal temporal language area, stimulating all the gyri, superior, middle, and inferior temporal gyri. And then and also from the anterior part of the temporal lobe, we got a response from ATLA only from the superior temporal gyrus, not from the middle by statistics. When we stimulate Broca's basal temporal language area, we are able to get a response from both from the anterior and posterior temporal language area. And if we stimulate anterior temporal language area, when we stimulate the posterior part of the basal temporal area, we also get a response only from the posterior part of the brain. And among them, between them, there is a response with each other, like this. If we see the gyral specificity, because we can locate electrodes on gyral basis, stimulating the inferior temporal gyrus here showed response from the anterior temporal language area, but not from the fusiform gyrus. That was, although the number is low, it was statistically significant. If we stimulate, and also from the posterior temporal language area, both gyrus were connected. In terms of the anterior-posterior axis, anterior part of the compared with BTLA electrodes connecting to the posterior temporal language area, BTLA electrodes connecting to the anterior language area were located more anterior. And among 10 electrodes, 7 were connected both to the anterior and posterior language area. So in summary, the anterior part connects to both the anterior and posterior language areas, whereas posterior part only connects to the posterior part of the language area. This was true in the opposite way. Compared with responses from posterior temporal language area, that was here. Responses from anterior language area, stimulation of the posterior temporal language area showed response like this, whereas stimulation of the anterior language area showed much more anterior response. So again, this was the same. Bidirectional connectivity between the anterior part and posterior part. To summarize here the connection, in the temporal language areas, there was a connection between anterior and posterior language areas in a bidirectional way. And from basal temporal language area, the anterior part connects to both anterior and posterior temporal language areas, but posterior part only to the posterior language area. Diurnal specificity was shown from posterior language area only from the superior temporal gyrus, and from the basal temporal area only from the inferior temporal gyrus, not from the fusiform. And let me discuss this part. Which fibers play a role in these connections? This is from modified from Dronkart's group, and this is from for diffusion tractography studies. It would be difficult to trace fibrous terminals into the cortex because of SN ratio, and also information may lack in the ventral temporal area due to the technical limitations, that is distortion, because of the air issue. So many studies neglect the basal part of the temporal lobe, but I think it's partly because of this methodological issue. And this is what I cited from Dr. Katani's recent study. These are the players for the connections. And what I showed here, I believe would be not through these large, long-distance fibers, but more maybe with U fibers. That is not very short one, but some intermediate one. That's what I believe. So going back to several hypotheses, it is true that anterior and posterior language area connects with each other, not by a primary auditory cortex. And for the basal temporal part, it has connection both to the anterior and posterior part, but anterior part connecting to both parts of the lateral area. And I am not quite sure how can I interpret this in terms of dual language pathway. I think dual language pathway, one should be like from, let's say for speech processing from auditory cortex, primary one, by superior temporal gyrus to Broca's area, that would be for sure. And by STG to the Broca's area, that would be okay for the arcuate long segment. But for the basal temporal area, I am not quite sure which part this belongs to. I would say this would be somehow different, and maybe having a kind of semantic center connecting to both pathways. This is a 5-storied pagoda in my in Nara city where I was born, and you may enjoy this kind of temple when you come to our country. And I think I spent 45 minutes. I can stop here, or I can talk brief about this. How shall I do?
Maybe we can take questions now, and if people want to stay for the final part, we can carry on. Any questions?
What about like the apraxia, ideomotor apraxia that you're showing? I was wondering whether you try to test with the left hand of the patient. As you may know, apraxia is a syndrome of the left hemisphere. So they should have ideomotor apraxia with the right and the left.
Yes.
And the may solve your problem of testing when you're stimulating in the frontal lobe.
Well, that's a good question. And for these two patients, actually we just could able to test their right hand, not the left hand. Future that would help us for the frontal lobe issue, whether they are managing both hands or not.
Second question?
Second question. Well, you said along your talk that you're using a 50 Hz stimulation, which is a gold standard. So I had a general question for you, whether or not when you're changing the frequency of the stimulation, you can see some change in the areas that are apparently connected or reactive to the stimulation.
For the mapping purpose, to map the cortical function, we use 50 Hz. And I wonder why 50 hertz. This was developed by my mentor in Cleveland Clinic, Dr. Hans Lugius. When I asked him, he said, I just think of hit upon number of 50. And it worked quite well, and they start using it. But some people now, because 50 hertz is very high frequency, some people, especially in United States, maybe from Florida, they use 10 hertz, and they said it would be fine, works fine as well.
Do you think the network will change?
And we believe for this cortical mapping, what we are seeing is not network, but the cortical just beneath. That is mainly affected. But you are quite sure single pulse conveys information, travels to the other part of the network, and we are not quite sure for the cortical stimulation what we are looking. I feel that we are looking cortical function just beneath it. But let's say for the basal temporal language area, it may be not only the cortex itself, but maybe the network that would be disrupted, giving rise to this variety of language impairments.
People that want to stay, I think it's 5 minutes more for the technical bits. It's probably more for the specialists if you want to stay. If you want to leave, you're more than welcome to leave now. And we do some questions later on. Okay, you can correct the last part.
So generator mechanism, this is a very difficult thing to solve. We know that stimulating a part of the brain surely shows response from the adjacent cortex as well as remote area. But the latency is not so short. Usually, even in the immediate cortex for CSEP, we got latency such as peak latency such as early 10 milliseconds, 12, 11, 10 at earliest. But it's just 1 centimeter, so people wonder why. This is an old study dated back in 1936 by Professor Adrian here in UK. They did the same thing, stimulating a part of the brain and recording the direct cortical response, DCR, from the immediate surrounding cortex. And what they found is the similar blunted waveform. They also did the multi-units recording here, like this, simultaneous one, and they found that unit recording, there is a jitter giving rise to mainly this kind of blunted peak. So they believe it's not only the stimulation activates directly a pyramidal neuron at the axon hillock, but it may be activating interneurons or axon collaterals going back to the pyramidal neuron. That may give rise to some oligoscopic jitter. And again, our CSEP response showed again the same kind of bluntedness. And we are not quite sure, so it could be direct, but we believe it's direct, but it could be subcortical by another place. For the lateral parietal-frontal network study, this is a surface distance between the stimulus and recording site, and this is peak latency. And you can have clear relation line that goes to the even in distance 0, there remains some latency here, 10 milliseconds. That may account for this kind of jitter. And this is a study in Coming Society for Neuroscience. Our neurosurgeon fellow did a CSEP study during operation to online monitor the function of the arcuate fasciculus in cases of tumor surgery. After removal of this tumor, stimulating the depth of the tumor that is close to the arcuate long segment according to the navigation, 50 Hz stimulation here showed the naming arrest. And when we apply single pulse stimulation here, what he found is evoke response from the Broca's area as well as Wernicke's area, although it's more inferior, like from the middle temporal gyrus. And here, this peak, N1 peak is like this, but we can see clear onset here. That is 6.4 and 5.6. And of course, we are stimulating Broca's area to record CSEP from the Wernicke's area, in this case, maximum in the temporal gyrus. and to online monitor the integrity of the language particles. For this, you can see the onset was 12.6. That is roughly equal to the summation of these two. And this was reproducible in several patients. In this way, we believe that the very fast response that is positive in polarity may be conveyed by the largest fiber with myelinated fiber. And in this case, I think that would be direct, not indirect. You may know this mountain. Do you know this mountain? This is Mount Fuji, close to Tokyo. And you can enjoy this Mount Fuji if you travel using our bullet train, Shinkansen. The conclusions here. CSEP provides a unique opportunity to physiologically track in vivo cortical networks, although applicable only during invasive evaluations. A standardized CSEP connectivity map provides a unique reference for non-invasive connectivity studies. It is clinically useful to identify functional cortico-cortical networks and its alternation due to pathology for the pre-surgical evaluation. And CSEP connectivity maps and diffusion tractography would complement each other to understand the brain networks underlying the human higher order brain functions from different perspectives. Thank you very much for your kind attention.
Any question right there?
Yeah, may I just ask, this idea of using it to predict your functional deficit after the epilepsy surgery, have you got outcome data to see how useful that was? So for predicted to the actual outcome after the surgery being performed?
So because this connectivity study, this is done when the patient is not doing any task. So the CSEP map itself does not show that it is related for some particular function. By combining together with 50 Hz stimulation, we can do so. So we show that for the praxis network, we are able to know that it is related with praxis. And for that patient, as I showed, although the language was impaired by sacrificing anterior part of the temporal lobe, praxis was preserved from the beginning. So we believe that the praxis network and language network is somehow separate.
Can I, if we were 50 years ago in Penfield and Robertson, they wrote this beautiful book on language, and but I was quite surprised to see that it was all about language and cortico-thalamic connectivity. So my question to you is there any way you can use this material to tell whether those areas are actually cortico-cortical or actually there is an indirect connection through the thalamus? You can see, can you use that latency, for example, to work it out?
Yes. As I showed for the intraoperative study, the intraoperative study,
yeah, that is one of the first examples that clearly is 6 milliseconds onset. That is
for this N1. These are very early, intense. Let's say for just 29, but on some occasions we do see late onset N1 peaking in 50s or something. Even in these language areas, the temporal language, temporal connection studies. And the reason here is very difficult. Once it would be, as you mentioned, or by old people like old famous doctors like Penfield, it could be bias harmless. And I cannot, it could be possibility. I don't have direct methods to prove it. But the other thing is, it may be because of the cortical site architecture or the fibers conveying connections in the association cortices. It may be not large myelinated fiber, or the cortical structure is somehow different. That may give rise to late blunted peaking in 40 or 50. Again, speculation. Yeah.
And I was quite. So is there anything that you can say about the inferior front occipital fasciculus? Do you have any electrodes that actually have been could you implant, or have you ever implanted, occipital and orbital-frontal cortex to see whether there is this direct track that doesn't seem to exist in monkeys? Well, we do see it in humans, but it's not.
Yeah. In our case series, we don't have that huge implantation, so I don't have direct evidence. But I think that is very interesting thing to find. If we stimulate the occipital area and if we found some from the orbital-frontal cortex with an early response, like peaking less than 30s, that would provide that it's a really direct response. But I don't have exact data, but let me see.
I suppose if you had severe enough brain lesion or epilepsy to justify recording over that area,
Yes,
it would be very difficult to kind of.
that's right. Usually we
It
have
like a resolutions kind of.
Exactly, yeah,
experience,
it's
the Usually-
whole,
yeah.
usually we hypothesize some
Yeah.
epileptic area, so we want to put less electrodes as possible. So, but that is very interesting
Yeah.
From academic point of view. So it's very hard to do such kind of study from our point of view. But let's see for temporal lobe study.
yeah.
For this posterior ITD stem here,
Yeah.
it's very posterior,
Quite
and
posterior.
we found some response only from here.
But that could be indirect, couldn't it?
I have to check the latency.
Because my guess would be, you can go from here to here and from here.
Yeah, that could be.
So that could be the pathway. You can't tell, can you?
No, I cannot tell.
Difficult to tell.
It's difficult to tell.
But can I just a final your model on this ventral? I mean, this is quite interesting because ventral language. Your final model for this.
Yeah.
This one, yeah. That could explain why, for example, this area I guess correspond to Lorancan visual world form area.
Yeah, the posterior part.
Posterior part. So that could explain, for example, why you don't have reading problems, maybe with more anterior stroke, because then you can always get this way around.
Yeah.
So, but actually, if you damage this area, this central hub, there's no way you can get either way this way. So you really got a kind of an obligatory passage there with that posterior area. So maybe it could explain some of the localization that we see. So why that is a visual forward from area. So I was quite interested about this. But do you have any experience of language problems in basal temporal?
I'm a pediatric neurologist.
Oh, right.
So interesting movement disorders.
For the anterior part here, when we sacrifice, we usually preserve so-called basal temporal language area. But and then usually patients have better verbal memory after the surgery. So better.
Verbal memory.
If we preserve. Our
I see.
neurosurgeon have a special technique to preserve temporal stem. They go into the cortical sulcus and just remove fizzy from amygdala, part of amygdala and hippocampus, preserving the white matter connections. It's very difficult to do, but they could. They may need technique for our patients. And for that purpose, we are mapping this area to preserve verbal memory. But sometimes we have to sacrifice some core language area where multiple language tasks are impaired. I had one patient in whom we sacrificed that area, resulted who is having a normal IQ over 100, good memory before surgery, with vector memory scale more than 100. Then what she developed is difficulty in reading kanji word at all. Even after the surgery, and also naming difficult. She could understand, she could speak somehow, but naming and reading kanji was quite impaired. But amazingly, in 6 months, his verb score was less than is around in 80s, went back to 90s, and in a year, she was okay with all kanji reading.
And the kanji reading is pictorial.
Pictorial, they need meaning.
Yes, it's kind of almost graphs,
Right.
isn't it,
Yeah.
or
Right, also
drawings.
yes.
Could that be explained why you have these language areas. I mean, the ventral bit is all to do with vision. The auditory one is more phonological, auditory motor integrations. So in English, that is, I think it's for your kanji reading. Have you done these studies in Japanese people? Or been that replicated, that ventral areas in American or English speakers?
In American people, they stimulate, in Cleveland they do, and they have difficulty reading.
Reading as well. Okay.
And here, people from evolution point of view, this is a homolog of monkey TETAO, higher visual cortex.
With small lateral.
But it could be heteromodal,
Yeah,
according to the result of ST, semantic dementia patient.
Exactly.
And
exactly.
so, for example, verbal auditory comprehension was impaired there.
Yeah.
And we also have some preliminary study that naming more synonym judgment kind of task is more impaired there.
Yeah.
So we
category,
believe
you got category specific as well.
yes,
and
we believe this is more modal, both auditory and visual. And again, this area was connected to both parts.
Yeah, exactly.
So that's what we feel. This is a kind of more language, more semantic than language.
Yeah, exactly.
If that is semantic, both sides can play a role, as in patients with semantic dementia. So some people is totally okay if their right side is functioning very well.
Yeah.
But sometimes the reality may be different. It might, let's say for my patient, so that may need 6 months to have reorganization of the network.
Yeah. But it also want the auditory motor.
Yeah, that's
more left lateralized, and it comes with the language.
And we want to see this dynamic change after the surgery to know what's going on in the brain after resection in the future.
Thank you very much. Thank you.